Share. Okay, so the first part of this lecture, we're going to go through types of anemias, and not all of them, obviously, to two main ones that you may encounter that you would give treatment for. And anemia basically is, we've talked about this a couple of times when we've talked about medications that cause bone marrow suppression, or anemia is obviously a decrease in the amount of red blood cells or a decreased ability of the body to carry oxygen. And we're going to talk about times that can be related to loss or decrease in production. These medications would not be given to people that have things like sickle cell anemia or problems where the red blood cells are destroyed too early. So we're going to talk about iron deficiency anemia, which is essentially either the person isn't getting enough iron in nutritionally, or they're chronically losing blood, so they start to wear out their iron stores. And the other type of anemia we're going to talk about is macrocytic anemia, which means the person has a decrease in production of red blood cells because they're missing some of the essential B vitamins. And it's called macrocytic because without those special B vitamins, the red blood cells don't divide correctly while they're being created, and they look too big. So we're going to start with iron deficiency anemia, and why that is important is that the red blood cell has many molecules of hemoglobin in it, and each molecule of hemoglobin has, what they're saying here, 4 heme units, and that's where oxygen binds, and the heme unit is made out of iron. So if I don't have that, then I'm going to produce red blood cells. I'm going to produce less red blood cells, and the ones I do might not have as many of those heme units to carry oxygen. So the treatment for iron deficiency anemia is to give iron supplementation, and we can either do that by mouth or IV. If we do it by mouth, the medication is ferrous sulfate. It can be a liquid or a pill. The liquid, you might need to dilute it. You should use straws, or try to, if you're giving it to a child, point it to the back of the tongue to try to prevent staining of the teeth. It's better to take it on an empty stomach because it'll absorb better, but it's hard to tolerate, so people usually need to take some food with it. The main complaints are GI side effects. They might feel nauseous, stomach pain. The ATI in the book say diarrhea or constipation, but by and large, the person will be constipated. That's the usual complaint with iron. And it will cause the stools to become darker and black because the iron that isn't absorbed from the GI tract will escape then in the stool. So the stool always gets darker, so the person should know that. And antacids decrease absorption, but vitamin C increases absorption. You can give iron by IV or IM. And the patient will still have some of that metallic taste from even the IM/IV kind, and could potentially definitely have darkening of their stools a little bit, but not any of these GI symptoms that the person will really have during oral supplementation. Oh, the hard candy is to take away the metallic taste in your mouth. So sometimes people hate that feeling so much that they would stop taking the medicine. But sometimes if you suck on some kind of candy afterwards, that can help decrease that sensation. The biggest risk with the IV type Right. So the oral, especially the liquid kind of iron, can stain people's teeth. The liquid iron can, and that's usually the type that a child will be on. So you just have to be careful when you're giving it so it doesn't touch the teeth. You use the hard candy not to avoid staining, right, because it's to take the taste out of your mouth. I just want to be sure that was clear. The biggest issue with the IV kind is that people can have an allergic response to it. So it's very important to give a test dose first to be sure that they don't have that problem. And then if they tolerate it, you have to wait an hour to be sure they don't have that. Then you can give them the rest slowly. The other issue with iron, especially if you're giving it as a supplement to children, and it's added to a vitamin that's like a gummy or is the ability for there to be iron toxicity, which could be fatal. So iron should be kept up away from children, and that's the biggest issue, is that potentially it could lead to over-ingestion, which can lead to symptoms of shock, low blood pressure, and eventually could hurt their kidneys or brain. If a person does experience iron overload or iron toxicity, you can give them a reversal agent, which tries to pull the iron and bind the iron, and that's the name of that. It's deferoxam. So that's iron deficiency anemia. So if you have loss of iron, then you give people extra iron. Ultimately, it'd be good to find out the actual source of the iron deficiency anemia and treat that. So then that's taken care of. The other type of anemia is something called macrocytic anemia, where the red blood cells get too big, and that would be an example of one of them. And it commonly occurs, people complain of what is called a glossitis, or an inflammation of their tongue. The tongue looks kind of cherry red. And I kind of mentioned that last class, although you might not remember that all the way. There's metformin, because it changes digestive patterns, can sometimes lead to vitamin B deficiency anemia, which has all the symptoms of anemia, except it has some extra symptoms like those tongue symptoms. Usually the issue could be, of course, that the patient isn't getting enough vitamin B in their diet. This is particularly vitamin B12, but sometimes it's because the person actually has some kind of autoimmune disorder that's decreasing their ability to make intrinsic factor. An intrinsic factor is a special protein that allows iron to be absorbed later on in the intestine. And so some people just don't stop having the cells that are able to make that intrinsic factor, or maybe they had part of their stomach removed, so they just don't have enough intrinsic factor. Because what's supposed to happen is you eat something that has vitamin B12 in it, and then the intrinsic factor gets released from the cells of your stomach, and that intrinsic factor will bind to the vitamin B, so that eventually, as it gets down to the end of your small intestine, it can be absorbed into your body. So if that's the problem, you can give vitamin B12 replacement in order to facilitate that, because your body needs the B12 in order to make red blood cells. So they'll make less red blood cells if it's not present. So cyanocobalamin, I said it, it's hard to say, is B12, and it can be given orally if maybe the patient just isn't getting enough food with B12. But if the problem is related to intrinsic factor, oral supplementation isn't going to be can it be twisted or obstructed intestine? Oh, as the cause of B12 deficiency? Potentially.
Yes.
It would have to be for a while that was an issue if someone wasn't if food wasn't coming down to the lower part of the small intestine over time, that would cause all kinds of nutritional deficiencies. So that could. If the B12 deficiency isn't related to a problem in the stomach, like the intrinsic factor is being made, then you could orally supplement it. If the issue is the intrinsic factor, then it's usually better to supplement by a non-oral route. And so that's usually a question on the exam about B12, because it is really important that you know if the B12 will get absorbed or not. So if I give somebody extra B12 by mouth, but they don't have the intrinsic factor to help it absorb later on in the small intestine, then it doesn't matter how much B12 I give them by mouth, they're not going to get it. So those people who have a special kind of anemia called pernicious anemia will have to get their B12 supplementation sub-Q or IM, and they would usually have to go in once a month and get that as an injection, maybe in the doctor's office or whatever. When you first start correcting the B12 abnormality, as the red blood cells start to increase their production, the biggest risk for the patient is hypokalemia, because there's potassium in the red blood cells. So if I start to increase production, I don't like that tip. If I start to, increase production, then I will have decreased potassium. So that's the biggest side effect. The other thing that can happen is high blood pressure or edema. And then the last type of anemia that we'll talk about that you can give medication for is folic acid deficiency. So folic acid is another one of the B vitamins. It's absorbed in a different spot. There isn't like a cofactor, there isn't an intrinsic factor or something else that helps it absorb. It gets absorbed in the first part of the small intestine. And so typically people that have folic acid deficiency aren't getting it from their food. It is associated with alcoholism. Or if the person has had surgery on part of their small intestine, so they're missing part of it or something like that. So it's very important for neurologic functioning. So the person might still have those symptoms of like the sore tongue, along with symptoms of anemia, but they're most likely going to have other symptoms related to problems with their brain, like being very forgetful, trouble concentrating. They might notice numbness and tingling at places too. And we always tell women who are thinking about becoming pregnant to supplement with folic acid before and during their pregnancy, because that one last picture right here is showing you that having a deficiency in folic acid can lead to neural tube defects, specifically spina bifida. So you can supplement folic acid, and it can come in many different ways. It could be by mouth, sub-Q, IM, IV. The biggest issue, and the one that ATI mentions all over the place, is that it's possible that if you only supplement with folic acid and there is some decrease in symptoms, you might mask a B12 deficiency, which is still important. So if someone's anemic and the cells look really big, they usually do another blood test to see, are they lacking folate, are they lacking B12, or are they lacking both? So you don't just want to automatically treat with the B vitamin until you know which B vitamin is the problem. Folic acid is generally well tolerated. People might notice a change in the color of their urine, which is harmless, but it is associated, if you're taking it for a very long time, with different types of cancer, an increase in cancer risk, specifically colorectal and prostate cancer. So that's anemias. There's only a couple medications that go with anemias. It has to do with replacing something that the body is deficient in so that production can increase. So iron, B12, and folate. And then the rest of this lecture will be about the hemostasis and anticoagulation. And then we're going to do some heparin math, which is always on this next test, which sometimes is difficult. It's a little bit different, or just a little bit extra step to how we think about some of the math problems we've done before. So I just want to be sure that we go through that together. So hemostasis, or stopping bleeding, has several steps, and those are the steps that we can manipulate if we want people to not clot their blood as easily. So first, obviously, there's some kind of injury. The blood vessel will actually contract as a way to stop some blood escaping. In the very beginning, it'll spasm. It doesn't stay that way. And then platelets will be triggered to sort of come to that area where the injury is, and then the clotting cascade will form what's called fibrin, which is a bunch of threads. So first you get the material, the platelets, and the fibrinogen all together so that you can make the clot, and then the clotting cascade's job is really to strengthen the clot by being sure that the threads are present and pulled tight. So if we look at this a little bit closer, there's a damage in the vessel where red blood cells are escaping, and that is how platelets get activated so they can form the platelet plug. And then we have to develop those strands to make the clot very strong. And so once there's an injury, as the platelets are starting to bind together, the clotting cascade is actually also starting. And the very end part of the clotting cascade is activated factor 10 is right there. And it changes prothrombin to thrombin. And thrombin changes fibrinogen into fibrin, which is what we want to strengthen and stabilize the clot. So there are two pathways to get here, which you may have had in physiology, and it doesn't matter all those separate factors that are inactive and then become activated. The final common pathway is this activated factor 10 changing prothrombin to thrombin, and then thrombin changing fibrinogen to fibrin, because those are the things that we might manipulate. Okay, Aisha, I thought that maybe you were. I know you're having trouble with your computer, so I am recording it, so at least maybe you'll get to look at it later. I'm sure you're really frustrated. Okay, so then eventually the other part of this is breaking down the clot, because once the clot is there, the whole point is to stabilize and stop bleeding while the immune system and factors that are left created by the platelets can heal the area that was injured. And then after that occurs, it's time to break down the clot. We don't want the clot to stay there forever. And in that case, after bleeding has stopped and the injury is repaired, tissue plasminogen activator will change plasminogen to plasmin, and plasmin can break down all the fibrinogen. It can break down that fibrin so that the clot can go away. So if we want to manipulate the clotting cascade, if we want somebody not to clot as easily, we can stop or change the ability of their platelets so that it's harder to make that platelet plug, or we can stop this someplace inside the clotting cascade. We can prevent the transition from fibrinogen to fibrin so that the clot isn't very strong. And that is a way that we can either prevent clots or give people medication if they've already formed a clot. Because if you've already formed a clot, you're not going to break down a clot by giving antiplatelets or anticoagulants. You're only stopping another clot from developing or making the clot that's there larger. If you want to actually break down the clot, get rid of the clot that's already been formed, then you have to give something that's going to activate plasminogen in order to break up the clot, and that is thrombolytic therapy. And so those are the medications that we're going to talk about now. Antiplatelet therapy, anticoagulation therapy, and then thrombolytics. So, and this is usually when people have an alteration in hemostasis, they could have a problem with their clotting ability or they're clotting too much. This we're not going to talk about as much. ATI doesn't go into very much either regarding hemophilia or people that have problems clotting. They do mention that you can give people blood factors separately if they have hemophilia to treat the ones that they're missing. But we're going to focus on medications that stop excessive clotting. So it's anticoagulants, antiplatelets, prevent clot formation or prevent clots from getting bigger, or removal of existing clots, that's thrombolytics. So antiplatelets, the biggest one we have is inhibition of platelet activation, and that's aspirin. We talked about aspirin in a different way in the beginning of the semester. We talked about its anti-inflammatory properties because it's a COX-1 and COX-2 inhibitor. And because it stops COX-2, that means it'll bring down fever, pain, and inflammation. COX-1 is how we get some of our side and adverse effects, because we could have a problem with the kidneys, since they're not going to get as much blood, or we could have problems with the stomach, because there's going to be an increase in acid. So we have to worry about gastritis, peptic ulcer disease, and we have to worry about a decrease in kidney function. Some of those things were a little bit more risky when the patient was taking aspirin at larger doses more frequently because of pain or fever. Someone who's taking aspirin in this setting is usually taking a baby aspirin, which is 81 milligrams, which isn't for babies. That's kind of a strange name to give it. A baby aspirin just means it's a lower dose aspirin. An adult aspirin is 325 milligrams. You can take 81 milligrams every day as a way to prevent clots. So the people that get antiplatelet aspirin therapy daily are people that are at risk for clot formation. You're hoping to start people on this medicine before they even develop a clot. And we know that there are several categories of people that are at increased risk of developing a clot. We want them to not have an MI or CVA. We don't want this. Stop it from happening. And so we would recommend, or a provider would recommend, that people with a history of hypertension and high cholesterol and diabetes might consider taking a daily aspirin to prevent them from developing clots that could lead to an MI or CVA, because we already know that people with these problems are at very, very high risk. So it's because we can give aspirin because it binds to platelets. It has that irreversible binding to platelets, which is why it promotes bleeding. So here's if I have a platelet, it's just a cell fragment that's going through the circulation. If this platelet sees that there's some kind of tissue defect or something that, might be a problem, the platelet will activate. And activation just means that the platelet gets sticky and it changes its shape a little bit. It has more surface area and it's more sticky, and that's how it can bind to other platelets. So if I have the aspirin that's changing the platelet, then I won't be able to activate the platelet. So obviously, if I had some kind of trauma, I want to activate platelets. You know, if I fell or was in a car accident. The reason why we want to stop platelet activation for these patients is that these conditions can trigger clot formation inside the blood vessel even though there isn't an injury. Because an injury like we would think of normally, like trauma, because these conditions, hypertension, elevated cholesterol, and diabetes, can injure the inside of the blood vessel, and the platelet will activate in response. And so if we give aspirin and that aspirin binds to the platelet, then we can't have activation and we decrease the risk of clot, which is beautiful. So how we know that it worked is kind of a trick question. There isn't a blood test. So this is an important point. If I give somebody aspirin and I want to know if it's working, there isn't a blood test that I can give the patient to find out if that's the case. Sometimes people will be like, oh, we'll check the platelets. It's not going to affect the number of platelets. It's only going to affect their ability to activate. So the only way that I know that the aspirin is helping this patient is that they don't have a stroke or heart attack. So it isn't a blood test, so be sure you remember that. There's no blood test for me to know if giving a daily aspirin to decrease clot risk is actually really working, because our CBC, or complete blood count, is only counting the number of platelets. It's not telling you the quality of the platelet. Okay, so say the patient is at even greater risk of CVA or an MI. It could be that they've had one before, so they've already demonstrated that that's possible for them. Or maybe they had a stenting procedure where they had an MI and then the provider put a stent in the coronary artery to try to keep it open. And these stents are at risk for clots. People can clot their stents, or what sometimes people call drop their stents. And then they essentially have the same symptoms again. So once you put that stent in, you have to protect it. And so the next thing you can do that would be even stronger than aspirin is to give them a medication that prevents the platelets from sticking together. So you're not preventing activation of the platelet, you're preventing the platelets from clumping together. And that medication is Clopidogrel, which is Plavix. So when this is showing you like an injury at the vessel, and this is showing you that platelets that are activated have these open receptors that allow them to bind to the area of injury and to bind to themselves. So here's my platelet, how it starts. Then it gets activated. So what it does is it exposes these receptors that help it connect to other platelets, which then allow them to connect to another platelet. And that's how they aggregate or combine together. So I could cover up these binding sites, then even though the platelets are activated, they can't clump together. And that's the way that Clopidogrel or Plavix works. So I could give it to people that I'm more worried about, or because they've already had a stent. This also lasts the life of the platelet, irreversibly binding to these receptors. So just like aspirin lasts the life of the platelet, which is 7 days, Clopidogrel lasts the life of the platelet, which is 7 days. So I don't know if you recall from the first semester or beginning of the semester, the first unit, that you had to hold aspirin for procedures, depending on what the provider said, for at least 3 to 4 days, but the best scenario would be to hold for 7 days. The same is true with Plavix, although depending on their risk, the cardiologist or whoever put them on it might say, oh, I guess I'll give you some platelets that are working, so you can only hold it for 3 or 4 days. But for our exam, we want it to be held for 7 days. Do not crush or split it. Commonly, people will have, headaches, some dizziness. The biggest issue, of course, is bleeding, because same with aspirin, we don't want the platelets to get sticky or to bind together, because we don't want them to do that inside of a vessel that's sort of sick with whatever conditions we have. But if we do that, then what happens if I actually fall or cut myself? When I need my platelets to do their job, they're not going to be able to. So the person is going to have easier bleeding and bruising. We just want to be sure that they're not bleeding excessively, which could happen. Usually people don't take aspirin and Plavix together for that reason, although sometimes you'll see that they do. And there is usually things we would tell them to do to try to protect themselves from injury. It's not time to join like contact sports. If they're going to do things that could potentially cause an injury, they should try to protect themselves, like with gardening or other household tasks. They should try shaving with an electric razor, which tends to cause less cuts and nicking, because that might be hard to stop bleeding if that occurred. And they should use a softer bristle toothbrush. So that electric razor and soft bristle toothbrush are ways to protect the patient from sites that bleed a lot. It's easy for the gums to bleed, so that's why you have to be careful with that, and it's easy to bleed during shaving. In a normal, even if you're not on these medications, it can sometimes be hard to get a nick from shaving to stop bleeding. And then the next step is to, if you want to do something more because the patient's risk is even greater, you could actually use an anticoagulant. So aspirin and Plavix or Clopidogrel are both antiplatelet medications. Warfarin, which is Coumadin, heparin, and Lovenox are medications that inhibit the clotting cascade so that you can't get that fibrin material. And people are generally placed on, they're placed on these medications for several reasons. So heparin and Lovenox are similar, but a slightly different mechanism of action. So we have that factor 10 that gets to be activated. Well, if I can draw this correctly. Activated factor 10, and activated factor 10 changes prothrombin to thrombin, and then thrombin is what changes fibrinogen to fibrin. So heparin and Lovenox act on this step. They either prevent this from happening or directly get rid of this factor so that you produce less thrombin, and which explains why the test you do is to check the activated partial thromboplastin time. You're trying to be sure that prothrombin isn't activated to thrombin. So this is the blood test you check. So if somebody is on heparin, you can check the PTT to see how well it's working. Unfortunately for Lovenox, there isn't a good way to test how well it's working in terms of a blood test. It's a little bit harder to manage. It's less injections, so people like it for that reason. But you can't, there's no blood test, and no easy blood test to tell you if it's working too much or too little, and there's no reversal agent like there is for heparin. So why would somebody go on this medication, heparin or Lovenox? There's a couple reasons, and depending on what the reason is, depends on how you would monitor them or what their risk is. So you may have, if you've gotten to go into the clinical situation, or if you happen to get to do this because of your job, you may have a patient that is getting daily Lovenox or heparin in the post-operative setting or in the setting of prolonged hospitalization. Those people getting Lovenox once a day or heparin 3 times a day are just getting it at a lower dose to prevent a clot from happening. And those people are getting what's called, and this is where it gets a little complicated, subtherapeutic anticoagulation. So we're not trying, this is the post-op patient or the patient who's going to be in the hospital a really long time, because having surgery or being in the hospital and being immobile for a long time increase your risk for clots. Everybody, no matter what your history is. So what I mean by subtherapeutic is the dose is lower, and so there isn't a blood test that I check on a regular basis to see if it's working. I know it's working because the patient doesn't get a PE or a DVT. So what are the symptoms of a PE? Right, so if someone has a pulmonary embolism, then they're clotting off part of the blood vessels that go into where the alveoli are, so they're not getting enough, they're not going to get enough oxygen. It doesn't matter how much they breathe, if the blood flow isn't in there, then they can't have gas exchange. So shortness of breath or dyspnea is good thing to mention, because it's not just that they feel short of breath, the breathing is uncomfortable because they're not getting what they need. Sometimes they will cough up blood if it's very, very severe, and there will be hypoxia because they're not going to get enough oxygen. What are the symptoms of a DVT? Potentially pain. Warm, swelling in leg or calf. Correct. So the biggest issue, especially for a DVT, is it's usually unilateral, meaning only one leg is affected. It shouldn't really cause hypoxia to the leg because it's not the artery that's affected, it's the vein. So they get swelling, but they're still getting arterial flow, so they still get oxygen exchange. But they end up with that painful swelling. It can be sometimes red, and it's usually unilateral. So the only way that I can know, so you guys know those symptoms, so that's good. The only way I know that my subtherapeutic anticoagulation, or those sub-Q heparin shots 3 times a day, or sub-Q Lovenox shot once a day is working, is that the patient who just had surgery or is in the hospital for a really long time does not get a PE or DVT. So exactly, so having had surgery or being immobile will increase your risk of clot in and of itself because you're not moving. That stasis of blood can sometimes trigger a clot. So that's why they put those TEDs on. That's why I put the SCDs on, because you're trying to keep the blood moving in the lower leg to prevent clots. But that isn't even enough. People will still sometimes get clots. So that's why they use the low dose. So the point to get across to you is that when they're on this lower dose, subtherapeutic dose, because they just had surgery or they've been in the hospital a long time, there is no lab that I can do to see if it's working. So there's no blood test. All I know for the prolonged hospitalization or the patient that just had surgery, the only way I know that this worked is they don't get a PE or DVT. So that's important for the low dose kind. Well, that's different. We'll talk about Coumadin. That's different. You're treating a different problem. So hold that thought, Natalie. So I could decide to give somebody higher dose or therapeutic heparin or Lovenox if they've had a clot and I want to prevent clot extension, or I don't want the clot to get bigger, or I have to do something called bridging, which we'll talk about again when we talk about Coumadin, someone who has to be on constant anticoagulation. So I can give higher dose heparin and Lovenox in the situation where the person actually had a clot. So they're in the hospital, despite our best efforts, they got, we tried to ambulate them, we put their SCDs and DVTs on, we gave them fluid, we gave them their subtherapeutic heparin and Lovenox, we gave them the low dose heparin and Lovenox, they still got a clot, which does happen. Then, or they're out in the community and got a clot because maybe they have a clotting disorder that they didn't know about, something like that. In the very beginning, when the clot is there, I can put them on high dose or therapeutic heparin and Lovenox so that the clot doesn't get bigger. So this is much higher, and in that case, especially for heparin, is when I can do the blood test, and the blood test is the PTT to see if I'm in the right range. So this medication inactivates this area where factor 10 is. So we don't allow this to happen, which means we don't allow prothrombin to become thrombin. So we stop the clotting cascade of that section. And this is the blood test we check. So here's the patient on their, when they're getting it as in heparin, they will get a continuous IV infusion of heparin. And this is where the math comes in that we're going to do after our break. It's a weight-based math. You decide how to run it based on how much the patient weighs and how they respond in terms of the blood test. Lovenox, when it's given at therapeutic, is still injections, it's just much higher doses. So of course, with all of that, the risk is bleeding, and certainly the bleeding risk increases if you're giving it as a therapeutic medication. Some people, when they get heparin, develop something called heparin-induced thrombocytopenia, which is an autoimmune action. Heparin somehow triggers the body to break down platelets. That's not very common, but is possible. ATI goes into a whole section about the risk to a patient who has an epidural when they're on heparin or Lovenox at any dose, because where that epidural was placed, when you pull the epidural out, that's causing trauma that could eventually cause bleeding. So usually no epidural is placed after the patient has started heparin and Lovenox, unless it can be held for a while. Oftentimes people with major surgeries are given epidurals in the preoperative area before the surgery even happens. And in that case, they're going to wake up from surgery and they're going to be on heparin or Lovenox at some kind of dose. So it could be that they're getting better and they're now at the point where they can take pain medication by mouth, and so people are deciding to take the epidural out. Then all heparin and Lovenox has to be held prior to removal, and they'll have to be held for several hours, because if you pull the epidural out while the patient is still getting this medication, they can get a subepidural hematoma, which could cause paralysis to their lower extremity. So obviously that's not something we want. And anyone who gets too much heparin can get the reversal protamine, but there is no reversal for Lovenox. So that's the beauty of heparin. So if the person is on a heparin infusion because they had an acute clot, then you start it based on their weight and the orders. Now the infusion is going, you're going to be checking their PTT levels to see how they respond. So normal PTT, so you and I who are not on heparin, would be 20 to 40 seconds. We want this to be doubled. So the usual, what we're trying to do is from the baseline, but it depends on what the orders say. We would like, the PTT to be between 41 and 70, around there. If we get a math problem like this, I will tell you what the normal range should be. Anything above that, we would worry that it's too easy to bleed. So we would either decrease the heparin, or if it gets really high, we might have to give the protamine. If we were giving the heparin and the PTT was too low, that means we would need to increase the dose per our orders to get into the therapeutic range. And so we'll talk about that when we talk about the math. Now we're going to talk about what Natalie mentioned, which is warfarin or Coumadin. So this is a medication that somebody would take every day because it's a pill to prevent clots when we know either they've had a clot in the past, and so they might be on this forever or at least a year because they've demonstrated that they make clots. It could be that they have a heart valve. So either they've had a clot, they have a heart valve. Heart valves are very prone to forming clots, so we protect them by giving them Coumadin forever or warfarin. Or maybe they have a history of a heart dysrhythmia called AFib, which atrial fibrillation causes the atria to slosh around, so that can increase. Yes, Brianna, that is exactly what the answer would be. So if you're giving heparin IV and you want the heparin to be effective, therapeutic, then the PTT should be double the normal. That is correct. So that's interesting that was on. So obviously you couldn't have answered that one right necessarily because you didn't have it yet, so don't feel bad. Okay, so these are the reasons I might give somebody Coumadin, and they might take it for either the rest of their life or at least a while. And what Coumadin does is it actually stops the synthesis of all the clotting factors. Clotting factors are made in the liver with the assistance of vitamin K. Coumadin is a vitamin K antagonist, so then you can't make the clotting factors. But it takes a while. It can take 7 to 10 days for the Coumadin to actually be therapeutic, and the blood test we do for that is an INR. Most people are between 1 and 2. Someone that we want to not have a clot is 2 to 3. It can be a little bit higher if it's for a valve. Once you get 4 or over, you have a risk of spontaneous bleeding, just like when we had the PTT that was too high. And so our reversal agent is giving vitamin K. The issue, of course, with all these medications is bleeding. The other issue with Coumadin is they have to be careful about how much vitamin K they actually ingest. They should just stay how they always are, because if they increase their dietary intake of vitamin K, then they're going to have to increase their dose of warfarin. And if they decrease their dietary intake of vitamin K, they're going to have to decrease their dose of warfarin. So it's better that they just keep it at a stable amount so that we don't have to worry about that diet intervention. There's lots of medication interactions, so we also have to be sure that we're always watching that. So when do you sometimes do both? Well, say the patient, the first scenario that we talked about, and that means heparin and warfarin. The first scenario we talked about was that patient who's on the heparin because they had a clot. And if they have a clot, they're going to have to be on warfarin or some kind of anticoagulant for at least 6 months to a year. So, and we know that warfarin doesn't work right away. It's going to take 7 to 10 days. There's a little bit of a lag time. So we can leave them in the hospital and on the heparin while we're giving them warfarin daily so that their blood is still thin until we can affect their blood clotting with the warfarin instead. So this can get really complicated, and you don't have to worry about it because you don't dose it, but you can kind of anticipate it. So say you've had the heparin drip on for a couple of days, and usually once you get in a good rhythm, you don't have to adjust it very much. So the heparin is running, but you're still going to be checking those PTTs at least daily to be sure that it's in the right spot. Then the patient may be going to be discharged, so we're got to start working on what they could go home with, because they're certainly not going to go home with a heparin infusion. So they start warfarin, and we know that the proper range is 2 to 3 in terms of their INR, and it's going to take several days. It can take up to 7 days. Some people do it faster, but it's going to take at least a couple of days before that starts to work. So they're going to be checking the patient's INR every morning. So it doesn't matter what the PTT is in terms of the warfarin. It's not measuring the same thing. So the PTT could be in the range that means the heparin is working, the 41 to 70 range. So okay, we're good. But the INR could still be low, like maybe it's only 1.5 this morning. So we leave the heparin as is, but we still have to increase the dose of the warfarin. Eventually, when the warfarin makes it into this range, we'll be able to stop the heparin, and then the patient can go home on the warfarin. It could be the reverse. Say we have this patient who is always on warfarin, for whatever reason. Maybe they have chronic AFib, maybe they have a heart valve, whatever. So they're always on warfarin and they're in the therapeutic range, and now they have to have surgery. But their other physicians are scared because they've demonstrated that they're really good at forming clots, and so they don't want them to have a stroke or something. But maybe they really need the surgery. Maybe they have cancer. So you have to decide, what are we going to do? And so if the risk of clotting is so bad that we wouldn't want to hold the warfarin for 7 days, because that's a long time, we could bring them into the hospital and start heparin and get the heparin at a therapeutic PTT, and then we can stop the warfarin and wait till the INR gets to a point where it's safe to operate on them. Because heparin you can hold, and after 6 hours its effects are gone. So that way the patient is with their anticoagulation as long as they can before the surgery. So now they're in, the warfarin levels are down, so we know that that's not affecting their bleeding times anymore, their coagulation. So then I stop the heparin the night before the surgery because I know they're going to have surgery. They have the surgery, they wake up, there's going to be a little bit, a couple hours maybe, and then they'll restart the heparin. And then they'll keep the heparin going for a couple days before the surgeon says it's finally okay to start the warfarin. And that's called bridging, which you may have to do either way, depending on what's happening with the patient. So again, we have to be sure if we're giving the subcutaneous injections that we're giving them correctly. And for anticoagulation, that means no massage, because that could increase trauma to the area and bruising. It's best to give it into the belly because there's more fat there. We should instruct them on ways to minimize injury, so that's those electric razors and soft bristled toothbrushes. And in terms of interactions, we mostly have to worry about warfarin because it has multiple drug interactions, and we have to worry about the dietary interaction with vitamin K. So we will go through that again when we're talking about the math, because that comes into it again, the blood levels. So for now, we'll just talk about the thrombolytic therapy and then take a little break. So thrombolytics are they're actually busting up the clot itself. So this picture, I mean, it's amazing what it can do. I mean, I've given TPA or Alteplase to patients who've come in with strokes, and their stroke completely reverses. I've given, when I worked in the ICU, you can direct the thrombolytic therapy right into a vessel that acutely clotted to get people to have flow back into their arm or something. It's really cool. It's very dangerous though, so it has particular strict parameters on who can use it. And so this is showing you what's called an angiogram. So the radiologists inject dye, and the dye stops here because there's a clot, so everything isn't getting blood flow. Well, or right here actually, sorry, this is it going in. Now once they gave the thrombolytic, all those vessels open up. So tissue plasminogen activator means that we're acting plasminogen to plasmin, and plasmin is the stuff that can break up the clots. So our body has its own natural tissue plasminogen activator. We can give the synthetic kind, which is Alteplase. So it'll break down the clot because it breaks down the fibrin. But now this patient is at increased risk for bleeding because we gave this medication, which is breaking down clots. And if there's any other area that's weak in the body that could be injured, then that area could bleed. Or if there's other places that have just recently healed, then those areas could bleed. So we have to be very careful that we pick the right people for this therapy. You can give a hemostatic agent. It's not really reversing the Alteplase as much as it's stopping excessive bleeding. And this is the drug you can give, which is Amicor. Aminocarproic acid is what you could give to try to reverse the TPA if there's an issue. So once the person they've decided that they qualify for TPA therapy, you want to get any procedures done before it's given, especially venipunctures, because it'll take forever for them to stop bleeding. You'll pretty much be holding it for a long time to get that to stop. But even other things too, like a Foley or things like that, any trauma is going to bleed more. You want, afterwards they're on bed rest, they cannot even get up to go to the bathroom, they would have to have a bedpan. It's best to have their head of the bed up a little bit. And what you will monitor them for very, very closely is any change in neurostatus, because that could mean they have had an intracranial hemorrhage, any increase in abdominal or joint pain, because that's common places where people can bleed spontaneously as well. So how do we decide who is a good candidate? And it has to do with the time. The closer you are to the original insult, the better, the more successful it'll be. After these time periods, then it's not just that it won't work, but why take the risk? So if it's not going to work and the patient could bleed, I'm not going to do it. So if the person had symptoms of a heart attack and it's 2 hours, it's a good time to give TPA. You can bust right through that clot. Or if they had stroke symptoms and it's within this time period of 3 to 4.5 hours, then they might benefit from TPA. But these are absolute contraindications to TPA. That's if they've had a prior intracranial hemorrhage and they've demonstrated that they can bleed in their brain. So we definitely do not want to give it. If they have any lesion in their brain, so that says cerebrovascular lesion, like an aneurysm. If we already know that they have some kind of vessel weakness in their brain, then the last thing we want to do is give them a thrombolytic because they're going to bleed into their brain. If they've had any trauma in the last 3 months, so maybe they were in a car accident 3 months ago, and who knows what kind of injuries they've had inside, then they might bleed from those areas again. If they have severe hypertension, the reason not to give it is because hypertension in and of itself is a risk for a hemorrhagic stroke. If they've had a recent CVA, if they have a history of peptic ulcer disease, because it's going to bleed, or if they've had very recent surgery, because it'll bleed there. And you can give the reversal, but it's going to be hard for that person. That area where they had the surgery you might ruin all the healing. That peptic ulcer could bleed severely. Some sort of abdominal trauma they had could bleed severely, and it's not like you can hold pressure in that area. You might end up causing an extra problem. So you have to be sure that you pick the right person. But for the right person, it's very dramatic how well it works. So let's take our break. We did go over a little over, but that's okay. So it's 10 after 2, so at 20 after 2, we'll do some heparin math together. So come back at 2:20. Okay, so can everybody please check in if they're still here? Okay, so it looks like most of you, I don't see Marissa or Sierra. So if you guys are here, Natalie, Kelsey, or Brianna, if you're here. I think that's who we're missing. Oh, Sierra. Good, good, good. So Marissa and Brianna, if you're here, let us know. Okay, so the last thing we're going to look at is some of the types of math questions that you might see on this exam. And it won't be like some of the other ones where we've calculated the concentration of liquid Tylenol, or looked at how to run a mini bag for, thanks, Alyssa, looked at a mini bag of like antibiotic and how fast that should go. Instead, it'll be questions about what we're going to be doing with this heparin drip, this weight-based heparin protocol. And the way that generally looks is like this. It'll be a big order sheet. So your patient will be starting on a weight-based protocol. And let me just be sure I'm recording, because I can't remember. Okay. And it'll be based on their weight. And it should be in kilograms. These two here are stable. It's always the concentration of the heparin bag, or what you're going to infuse, hang from that, running through the infusion, the IV machine. Wow, sorry. That bag's concentration will be 25,000 units and 500 milliliters, although you'll be given that information so you don't have to memorize it. And the vial of heparin is like that little glass vial, and the concentration is usually 1,000 units in 10 milliliters. Again, that information will be given to you so you do not have to memorize it. You need both of those things because occasionally the patient will get a bolus of heparin, like they get when they first start it, or sometimes when the drip level is changed. You would give a bolus, and that you would just pull out of an IV vial and push into their IV. You wouldn't, take that from the bag. You would take it from this vial. So anytime you see that the patient needs a bolus, then you know that we're referring to the vial of heparin. If we're trying to figure out the heparin drips rate, like how many units per kilogram per hour, then we know that we're dealing with the heparin bag, because that's the one that's on the IV pole and that we're going to run and figure out how to give. So, the heparin will be hanging. And it'll be running through an IV. It has to run through an IV because you don't want to give too much or the person could bleed. And this is at the port closest to them. You could give, fill a syringe with heparin and give the bolus right there if you need to. Heparin should be run by itself. There's a lot of incompatibilities with medications, like antibiotics and that stuff. Sometimes you do need a backup, especially if the rate of the heparin is very low. So I'm not sure if you've ever heard the saying, to keep open. There's a certain rate that all IVs, if we want the IV to be open, where there's constantly fluid being pushed through the IV into the patient's bloodstream, the rate of the IV has to be at least 20 milliliters an hour. If it's lower than that, then you can't be certain that that's fast enough to actually push anything into the bloodstream. So if I'm running my heparin infusion and it actually ends up being only 10 milliliters an hour, which is entirely possible, then I do need another bag that is running with it so that I have a to keep open rate. And so it would have to obviously be compatible. And usually you would put up a small bag of saline. That's not something that will be on the exam. I just want you to know that, because that is information that will come up when you're in clinical, stuff like that. There's a to keep open rate. Again, that would be the only things that you would be putting in this particular IV line is, either the to keep open bag and the heparin or just the heparin. If the infusion is fast enough, you would not give any other medications through there, only the heparin. Okay, so now you're going to have the patient's going to start this infusion. So the infusion always starts with a bolus, which means I'm going to be pulling that medicine out of the vial, which is that 1,000 units and 10 milliliters. And I have to give them 5 units per kilogram. So the first step is obviously to figure out how many units. So that's 72 times 5, which is 72 times 5 is 360 units. So I am going to pull that out of the vial. I want to know how many milliliters I need, because that's what I'm going to pull into the syringe. So I want to end up with milliliters. So I need to give 360 units, and this vial's concentration is 1,000 units in 10 milliliters. Then I will be left with milliliters. So 360 times 10 is 3,600 divided by 1,000 equals 3.6 milliliters. So that is the medication that I would draw up from that vial, and I would give that in the IV, and it doesn't have to be given very slowly, like it's not over like 10 minutes or 5 minutes. You just sort of push that in. And then I need to start the heparin drip. And so then I need to focus on this part, the concentration of the bag, which is 25,000 units in 500 milliliters. So the provider states that I need to start the heparin drip at 20 units per kilogram per hour. So we know they weigh 72 kilograms. So it's 20 times 72, right? It was 20. I always forget in the middle. Okay. So, all right. So I can do that. 20 times 72 means I have to give 1,440 units per hour. But when I'm running the infusion pump, the IV pump, I have to know what I'm giving milliliters an hour, because that's how I set up the pump. So my concentration of the bag, and then I can get rid of units, and I'll be left with milliliters per hour. So it's 1,440 times 500, which is 720,000, divided by 25,000 equals 28.8 milliliters an hour. And this is how I would program the pump. So heparin infusions are rounded to the nearest tenth. So that's what I would start it at. So now I've given my bolus and I've started my heparin infusion. And then there'll be an order that after 6 hours, I'm going to need to be sure the lab is drawn so I can see what that PTT is. And just like Brianna reminded us, it should be 2 times the patient's normal. So usually people obviously have their blood drawn before this. However, when you get these orders, they will leave as little up to guesswork. So here it says, if the PTT is less than 50, we would increase the heparin drip by 2 units per kilogram per hour. If it's between 50 to 70, we would continue at the same rate. So that means we would stay at the 28.8. And if it was greater than 70, then we would bring the drip down to 2 units per kilogram per hour. And then we're going to always calculate to the nearest tenth. So, okay, here's my bag. I gave that bolus. And now what if, well, it's the same problem over again. So what if the PTT is greater than 70? Then I would have to increase by 2 units per kilogram per hour. Oh, thanks, Brianna. then I would have to increase by 2 units per kilogram per hour. So we started at 20 units per kilogram per hour. So that means we're going to increase by 20 units plus 2, because we weren't at the right. Oh no, I totally lied there. What was it? We're decreasing. Sorry, my bad. 200 minus 20 minus 2. Apparently I want to have a meta error really bad. So 18. So now I'm back to 18 times 72 to get the amount of units. 18 times 72 is 1,296 units per hour. Same concentration. We're getting rid of the units. 1,296 times 500 is 648,000 divided by 25000 is 25.92. So I would run it at 25.9. So that's my new rate. What if it was still too high? That's not what the math test says, but let's just pretend. Anyone else have a hearing issue? No one has said anything about the hearing. Nope. I know there is issues with Skype. You could try logging in and out, or check your speakers. Okay, so let's pretend it's not what the math paper says. Let's say, okay, we drop this down to 25.9 milliliters an hour. It's 6 hours later. I know. It's 6 hours later, so we say, okay, it's still 75. The PTT is still 75. So that means our order set said that if it's above 70, then we need to decrease by 2. And then reconnected me, but now I can't hear. It's so annoying. Okay. Another class I taught, I just got kicked off for like 10 minutes. I couldn't get back on. I have no idea why that happens sometimes, and it does. Okay, so here's our patient. They were over 70 after we started the initial infusion. We readjusted the heparin infusion. It's 6 hours later, and it's still over 70. So that means we need to decrease again, but we need to always adjust from where we left off. So we left off at 18 units per hour. It's still too high, so we have to subtract 2. So now we're going to be 16 units per kilogram per hour. So that means they still weigh 72. 16 times 72 is 1,152 units per hour. Again, it's the same bag. So 1,152 times 500 divided by 25,000 is 23.04. So we will be running at 23 milliliters an hour. And then if 6 hours later, we draw the PTT, and it's within the range that the provider's orders say, like between 50 and 70, then we would just leave it at 23 milliliters an hour, and we wouldn't check again until the morning. And then in the morning, it could be that it's normal, meaning that it's between 50 and 70, so we're just going to leave it at this rate the entire next 24 hours and not worry about it again until the next morning. Or it could be that it's maybe too low or too high, and then we'd have to adjust again. But whatever the PTT is, we're adjusting from where we left off. So we left off with the patient running the infusion. We were running it at 16 units per kilogram per hour. So if the PTT is greater than 70, then we're going to again subtract 2, but then from 16, so it would be 14 units per kilogram per hour. If the patient we came back and the PTT was actually too low, now it's less than 50, then we would again adjust from 16. So we'd go up by 2, so it would be 18. So when you're doing these on the test, the key thing is, of course, know the patient's weight. If the test question asks for a bolus, then that means you're using the vial, and you're going to write, the answer will be in milliliters, and you will give it whatever the order says, how many units per kilogram. If you're starting the infusion, it'll give you the base rate, so whatever, it could be 20 units per kilogram per hour. The base is usually around there. And then you're using the infusion bag, the concentration of that bag, and then it's wherever you left off. So maybe the test question says the patient weighs such and such, their current heparin drip is running at 25 units per kilogram per hour. The order says to adjust up or down depending on PTT, and the PTT is this. Then you would adjust it from wherever you left off. So those are how the questions will be. So I can put up other practice sheets. You can even Google heparin weight-based protocol, and you will see other examples of the same thing. But that's how you would run that. And in real life, a lot of times the computer charting will actually figure out the math for you. But I always like to double check the math and then have another nurse double check my math with me. Because the last thing I want to do is either give too little and the patient has extension of their clot or a clot, or give too much and the patient has bleeding. So that's one of the drugs where you should be double checking with another nurse. So did anything that I talk about make zero sense? I know. I can't see your faces. There's usually like one person in any class that I've given that totally gives me the barometer of the class, will look at me like crazily when I'm not making any sense. So now I can't tell. But that would be how those math questions will be on our test. So it'll be next class. Remember, you need to do the respiratory ATI and the hematology ATI. Yeah. They're trying to protect us old teachers. If we get COVID, we're totally going to be in the ICU. That's not even funny. I shouldn't even joke like that. Anyway, the test will be the usual 122 points. There'll probably be one or two fill in the blanks, and one, if you've noticed, that's true. You guys, a lot of people from Bryan and Stratton come back to school. Excuse me. And there'll be math. I will put these up as fast as possible because I know I was a little delayed last time. I don't, no idea why. I have no good excuse. I could make something up, but I'm not gonna. So I will try to process. They have to be processed. Yeah, I know. I hate to hear my voice, so don't ever make me listen to these recordings. So that's it. Email me if you have any questions. Don't forget to do your ATIs. I will look over the tests you just did to see if there's some problem areas that people have in common. And you are welcome, and I'll talk with you guys next week. So take care.